Welcome back, everyone. We'll wait a second for people to jump back on. Give it 1 minute to get our team back, small and mighty. Okay. And so we had a good segue just talking about our clients not being able to use resources. But one of the barriers to are working with clients and being able to provide breastfeeding interventions, as well as having the outcomes that we're looking to have, is sometimes there is lack of utilizing the resources that we either have as an agency or within ourselves. There can sometimes be underutilization of resources. Maybe there's some program that your agency has connection to, but you're not getting enough people enrolled in it. Or there's courses that people sign up to and they don't come to sharpen their skill set, et cetera. But we find these to be barriers not only to you being able to do the work, but particularly to the intervention and outcome that you're trying to provide for your clients. And so we were thinking about talking about when we talk about resources, we're talking about sometimes there's a lack of resources. Like your client needs to see an OT because their baby's having this issue and they're having a hard time getting that referral, or it's going to take 6 weeks when they get that referral through Medi-Cal, et cetera. Underutilization, again, talking about what services or resources you might have at your agency that aren't being used, that people aren't aware of, and if there are barriers to utilizing resources. So I know when I was working, primarily in social services, a lot of the things that we would have accessibility to, there were, extra forms that clients had to fill out. They had to give us their tax return. They had to, show how much they're paying in rent and give us their canceled checks. A barrier to someone who has a 2-week-old or who has other children running around. They're probably not going to want to engage in many of those services if there's so many barriers to entry. Sometimes language can be a barrier. When I was doing social services, I worked with monolingual Spanish-speaking families, and my Spanish is fairly good, but I also had a lot of indigenous families who spoke a dialect, not Spanish, not English, and I was not able to connect with them in ways that I felt I could provide more of those resources. And we didn't have anyone in our staff who spoke that indigenous language. Back then, you didn't have like the language lines and everything else that you could connect to. And so to me, that was a big barrier to services, that we couldn't actually connect. We know, particularly when we're talking about social service or healthcare, people are going to feel more comfortable speaking in their native tongue. And so that was a huge barrier to our services, that we were serving quite a bit of indigenous families and didn't have anyone who spoke that dialect. Sometimes people would have family members who spoke Spanish and English who could be able to help them and translate, but that wasn't always the case. And so that was a huge barrier in those families being able to get services, because a lot of times they would just shut off because they don't understand. They can't fill out the paperwork. They can't explain what's happening. And so that was a very unfortunate one of the barriers that I would see in the agency that I worked with. And so what we'd like to do is to have a little bit of a conversation about when we're talking about the resources. Sometimes those resources are addressing, things like we talked about unconscious bias or vaccinations, those kind of things. Our question for you is, the resource that you're giving your clients, where are you getting that information from? I'm assuming your agencies have, you have your resource lists that you tend to refer to, but even those, we would get like a binder. And I don't know if you guys have this, maybe we don't use the binders anymore, it's digital, but I'm aging myself. We had binders and it would have like all the resources, like, this is for parents who had a kid who was diagnosed with autism. We had, a Spanish speaking support group. Like there was lots of those kind of things. But how many times are some of those referrals unchecked, unvetted? So are you sending a client to this circle that's like a Christian circle and they're an atheist, and you didn't vet it out because you don't know, you're just like passing out brochures and not really sure what you're sending to your clients? And so, I would ask, how do you get the resources that you use for your clients? Are you vetting them? Is there some kind of sense of making sure that we're creating good fit for the clients that we serve? And so talk to me just a little bit. And we're talking about case management, basically. How do you manage these cases for clients that are complex? Like they have a lot of co-occurring things happening. There may be psychosocial, there might be economic, environmental issues happening. Yes, you're going in for the breastfeeding relationship, but again, they don't want to talk to you if on my mind is that I'm getting evicted next Thursday. And so where do you all get that information from in your agencies? Is it something that happens in case review? Are you just have like binders of information? Where's your resource go to for yourself and your agency and the clients you serve?
We have binders or folders. We also have electronic copies, but we have binders with different resources, and they're labeled from like legal assistance, childcare, environmental issues. And then once in a while, we also go through them, and because some of them are outdated or they no longer exist. So we've done that.
Yeah, it's important. Like, think about how frustrating it is for a client. The person that's supposed to help them gives them this whole list of numbers to call, and every number they call is disconnected because somebody created that list in 2004 and it hasn't been updated. Those small things like seem like not a big deal, but when you're on the edge, everything is overwhelming. And so if I'm actually taking the step to go and use the resources, that Shayla or Yvette gave me, and it's from something someone created in 2008 and that place doesn't even exist, or no one there actually speaks my language, or the people that work there are all rude, those are obviously things you can't know everything about it, but we want to take some responsibility that we're actually doing our due diligence to make sure that what we're giving to clients is in line with what the outcomes that we want to see and to really serve them in the best way. And so it just means sometimes, unfortunately, more work on your shoulders, which is difficult because you're already probably overworked and have more cases than you can handle in many places, depending on, what your caseload is. And so it's asking to do more work, but how do we also create that within our systems, organizations, so that it's not on your shoulders? Is there someone who does that within the office? Is there an admin person that's making sure that we have those kind of checks and balances for our clients? And that's really, really important. And so in thinking about resources for your particular agency that you work for, your particular organization, can you think of any resources in your agency or network that are underutilized? And if so, why are they underutilized? So just think, like, all the things you offer, all the connections that you have, are there some particular ones in your agency that aren't being utilized by clients or by, visitors, if that's the case?
I probably would say maybe the recreation and enrichment programs, that resources that we provide for the families to stay connected with that community. I think I've seen, because of either transportation issues, language barriers, and not being close to those resources. But we try to look for resources that are around their area and definitely look into that, right? Just emphasize, this is in your area. Is this something you're interested in? And making sure that it's something that they need, right? But it's definitely transportation with all those connecting the families with that community. For example, through this whole pandemic and everything, there was a lot of drive-throughs, donations, right? Food donations, diaper donations. And unfortunately, some of the clients do not have that other resource, which is transportation, right? How am I going to drive through if I don't have a car? With the ones that we do tend to use, but clients are not really following through with them because of other resources that are needed. In this case, would be the transportation or the language barrier.
And that's so important, because thinking about what you guys are doing, you're providing virtual sessions. So thinking about all the service, how many people would be interested in getting your services, but it's like, oh, I got to get to that office with 3 kids on the bus. That's 3 buses that I got to take. And I got to pay for bus fare, and I need that to actually get to work. A simple, seeing like, what is the breakdown? Why are people not utilizing is the way that we can actually provide more help. So knowing like they need to go to that diaper drive, but they don't have a drive up car. How do they do that? Do we have one at our agencies that people can just come by and pick up? Do we have something, once a month that, doesn't require you to have a car to be able to transport? Or if they come, they can get a bus, some bus tokens to go back. That kind of thing, we can make sure that our systems are set up. They can actually utilize the resources that we have. Anyone else can think of underutilized resources that they have at their agencies? I can think about when I worked at the hospital, one of the underutilized resources was car seats. We had free car seats to give people. But one of the barriers that people didn't want to be rude and ask them if they wanted a free car seat, if they, actually can afford their car seat. So their barrier was like, I don't want to offend people, so I'm not going to give them these car seats. Really silly barrier. An easy way to do that would be to do an intake form and say, hey, do you need a car seat or not? We don't think about these little simple tweaks that we can make to make our the resources that we have to be more utilized by the clients that need them. And we get in our own way by not doing that. Can anyone else think of simple things that people aren't utilizing, or you and your colleagues aren't able to utilize because of barriers, because of whatever they might be? Talking about underutilization. But that was a good one, Miriam. Thank you for sharing that. Transportation is a huge, huge one for our clients. And if when I was in social work, one of the things that we, oftentimes people obviously coming to a university are coming from all parts of the country. And so I went to school in Los Angeles. We had people who lived other places. I remember I had someone, talking about her client is always missing her thing. She said she didn't have bus fare, but like with a roll in her eye, like as if she made it up. I mean, who doesn't have 45 cents? A lot of people don't have that, but it was her own biases of like, everyone has $1. Everyone has $1.50. Actually, some people don't have $1. That is a real thing. And being able to kind of address that and kind of have a conversation like, maybe everyone has $1 in Vermont. I'm going to guess no, but here it is a lot for someone. And so one of the things that we had to do is that everyone had to take the bus to their field site. And I've been here 8 years. I've never been on an LA bus myself. And seeing what it was like to actually have to get somewhere at a certain time and what that took. And I had to get like on 2 buses. It took me 2 hours where it normally take me 40 minutes to get to work. And sometimes it's having that kind of realization of like, oh, what we're asking clients to do actually isn't that easy. If I was doing this with a baby and a stroller and my groceries, would that be easy? Probably not. And so I think it's sometimes being able to have those activities or conversations about what it really is like for our clients to experience our services can sometimes help us to break down some of those barriers. Lynette,
can you guys hear me? Yeah.
Can you guys
hear me okay?
Yeah.
Okay, I'm a little choppy, but I'm hoping that the phone picks me up. But it's funny that you mentioned that, Brandy. When Welcome Baby first started at our site, it was 8 years ago. We had no cases. We had no resources. So literally what we did with our time was go into the community, pretend we were a mom, and do what a mom would do for free. Go to the beach, call resources, act like you're a mom, trying to find, daycare on 211 to really like find it. If you want to talk about dating resources, and when I was a home visitor back in the day, I used to use the Rainbow Guide.
Oh, God.
You remember that? I kind of giggled when you talked about the binders. But yeah, like currently we're using our collaborations because everyone's so busy now in terms of like seeing patients. Our caseloads are a lot heavier. The only thing that we can use to actually vet our resources that we're giving is to, call out for a collaboration. So I know that, Charlene from LABBN knows most of the resources. I'm calling her to ask her for, a specific site that provides this type of service for a mom. So it's the only way I'm finding ourselves lately being able to vet, especially during the pandemic.
Right. And that's important. I think obviously things have changed a lot since our Rainbow Guide days. But, it's also, I feel like in a good way, you have these consortiums, you have, much more of the agencies talking to each other than we did before. And so there is a possibility to provide more, like, I know so-and-so who works at, DPPS, let me call her and see, is there a better way for this mom of 5 kids to go see about her benefits, or she lost her card or whatever. We can start to provide more of that because we are talking to each other a bit more, which I think is amazing. But yeah, those basic things, if you go into the community, you see how hard it is for people to access resources. We're also asking them to do that possibly under depression, economic, downfall, during pandemic. without transportation, with ailing health. We're asking them to do those same things that we have a hard time doing. We're asking to do that with all these co-occurring things. And so it's just important to think about a lot of the barriers to our resources really are about how we're getting in the way of actually being able to provide them. And you can't really see that if you're not thinking about it from the client's preview. So those are really, really good examples. Thank you all so much. And so because this has been a 4-part session, particularly obviously about breastfeeding and lactation, we like to ask the ongoing question for resources: how are you all keeping your skills sharp? Because again, all of you have had psychosocial training. You've probably had mental health training, you know, all those things you take it and you do all the time. Whereas when it comes to lactation, breastfeeding, it's something for most people, they're only doing more training, you know, if they have to like redo their license or they're trying to move up to another level. That's when they're doing like classes on latch or positioning, or you know, people who have like complex cases that need to be referred out for like a tongue tie or frenulum cut, that kind of thing. What are you all doing to make sure that your actual technical skills when it comes to lactation are staying sharp? Hopefully you guys will sign, your agencies will be signing up for more trainings through BreastfeedLA to make sure they stay sharp. But what can you do on your own personal level as a caregiver visitor to make sure that those stay sharp?
I would probably say stay updated, do your research, keep reading your binder that you have in the back of that bookshelf, and also practice, you know, continue implementing it, continue asking questions. Even though already the baby's been breastfed for a year, let's perhaps say, still ask, how is it going? Is there any other concerns, any questions? And I think that's what it will keep you going and stay updated on everything. So keep practicing, even with your doll at home.
Yeah, so the practice is good. And your community, you know, I don't know if any of you know each other or you're working in concert with each other, but you know, I've been doing it a long time, but there's cases that come up that I'm not used to seeing anymore. I'm not in a hospital setting seeing, you know, 40 to 50 people a day. And so there's things where, for me, sharpening is the community and being able to ask other lactation professionals, like, I have this case, this came up. What would you do in this situation? Like, what am I missing here? You have to have that ability to be tapped into a breastfeeding community, because there's always someone who's read more than you. There's always someone who has seen more clients than you, or who has seen this particular issue more than you. And so one of the biggest ways that we would say that you want to continue to sharpen your skills is to make sure you're staying in some sort of breastfeeding community, whether that means talking to other lactation educators or lactation consultants, if that means being in some kind of mentoring, you know, program, attending classes every couple months. You need to be able to have that space to do that. And so I think that leads us into exactly doing that by talking about your case studies. Part of this, you know, again, if we're talking about how do we break barriers, is being able to talk about the times where things didn't turn out the way that we wanted them to, or we had a client that stumped us, and being able to come to your community and to your circle and say, what could I have done differently? Why didn't this work out? Is there anything that you think I should have added or done differently to make this a better outcome? And so we will begin doing that. So did everyone have a chance to think about a case, to come up with a case that they can speak about, and basically how it works is that you will tell us about your case. We might offer some feedback, but then we will invite the rest of our community to give feedback if they're seeing things that they, you know, might have experienced or might have had a client like that did have a good outcome that they'll be able to add. And that's kind of how we will go through that. So anyone who wants to jump in and be brave and go first, feel free, or we will call on you. Go for it, Yvette.
One that I can think of is I had this one mom. This was the first baby, and this wasn't virtual though. Is that okay?
That's fine. Yeah.
Okay. And so I remember she was successfully breastfeeding off of one breast, but not the other one. And the other breast, she was pumping. She had tried, you know, using a nipple shield, that one breast. We tried, doing the latching using the techniques she was doing with the one breast that she was breastfeeding one. We tried there, but for some reason, baby was not latching from one breast only. And so she ended up doing, I think she ended up just continuing to just protect the milk supply and just pumping from that one breast. And I just told her she needed to see a lactation consultant at that point, but I don't know if we should have tried something different, or.
I can already tell you did the one perfect thing, and that's saying like, look, this is a higher level than what we can do in this session. You need to see a lactation consultant. So that's great. For our team, what questions do we need to ask Yvette to be able to know more about this case to provide feedback? What questions might we ask her? Like a question I might have would be, yes, you got it, Lynette. How old was the baby?
We know who you trained with, Lynette.
How old?
I'm sorry?
How old was the baby?
Yeah, maybe if I can remember correctly, no more than a week old.
Okay, so new baby. My question would be, on the other breast, was there any kind of abnormality about it? Were you able to see that breast?
No, I was able to see both. The only difference was the one where she couldn't breastfeed off of, the nipple was a little bit on the flatter side, but not flat.
Okay, got it.
Well, Yvette, tell us a little bit about her birth, protecting her privacy.
That I can't remember, but I just know it was her first baby. I think it was an uneventful birth, but I don't have details. It was when we were still doing home visits.
Right.
Okay.
So Lynette's asking.
Oh, go ahead, Brandy.
Lynette's asking, were there any physical abnormalities with the baby?
No.
You remember whether it had a good birth weight?
Yes, because at that point we're still weighing, so nothing. Baby was gaining weight because the baby was being fed.
Okay. You're gonna say something. Sorry.
Yeah, I was going to say, at this point, number one, as Brandy said, I just want to emphasize that you recognize the number one most important thing is out of your scope. And you can tell based on the questions that we're asking that all of the LCs are like this, like, ooh, okay, let's dig in. And that's kind of what we do is we start to problem solve around these things. But really when we're talking about very, very, very specific side preference, you really want to be starting to think, again, out of your scope, so not something that you're going to solve on your own, but you really want to start to be able to explain this as a reason why someone's going to go get an LC consult. So as opposed to oh, that's not my scope, you want to see an LC, and then they're like, okay, I'm fine, I'm just going to keep breastfeeding on the side because I know that's possible. You know that's possible. We know that's possible. Instead, what you can say are things like there's a lot of contributing factors to why baby might have a strong preference to one side than another. And a lot of them have to do with baby's overall structure, which could be informed by birth position or position in utero, what happened during your birth, and some other things that are going on, again, inside baby's mouth. And all of that needs to be evaluated. I would start by getting an evaluation because it's feeding related from an IBCLC. And from there, they might actually refer you to somebody else to do some body work, to see an OT or a PT that's going to actually address the larger system. And I think being able to really explain the why behind our referrals is so key, because a lot of times we think of things as just a feeding problem. And as long as baby can get nutrition, we're thinking it's okay. We know we can breastfeed off one breast, not a big deal. And the parent thinks that too, but really what we're missing here is the underlying cause for why this baby is struggling. And what that's going to do long-term, not only to the breastfeeding relationship, but also, is it possible there's something that's being missed that could be addressed really early with early intervention for this child? Because if there's that strong of a preference, we really likely have something going on systemically with baby. Was that helpful?
Yeah.
I do have a question. She mentioned that they tried every technique that she used with one breast, correct? Could it be that maybe in the right breast, the baby breastfeeds very well in a certain position, and for the other breast, another position might work? Could that happen?
Fine. Yeah. Well, number one, yes, anything can happen, Miriam. So yes, is that. But also, I actually find if you're looking for a quick fix to things, and again, I want to emphasize that there still needs to be a referral, even if we can fix it. You want to know why? Because again, there's that underlying issue that we don't want to ignore for baby's overall health, okay, and development. We really do have to figure out what is the underlying issue here. But I do find that a lot of times when there's a preference on one side, let's say that I'm going to get my baby. I've got to birth my baby. Hold on.
That's so funny. I went to go grab a doll to see if I can help do it.
Good. Yeah. Lynette's going to jump in next and do this for me. But let's say that that baby has a preference, a very strong preference for my left side. And we're breastfeeding very well in a cross cradle position. What I may do is start off on the side that baby is really comfortable on. And then I'm going to set up mom so that all we have to do when it's time to switch, once baby has established a good sucking pattern, is I'm actually going to break the latch and I'm just going to slide baby over to the next breast in the exact same position. Because what's happening sometimes then, if I go to cross cradle in this position, baby has a tightening, some kind of torticollis, baby has some kind of discomfort from something that happened in birth. Baby has something, again, if they were in utero, I will use my sweet daughter as an example because I know she wouldn't mind. My daughter had an 8.5-pound baby. She is 4'11". 4'11". So you can just imagine what my grandson was like when he was in utero with that baby. He was like this. Right? And when he was born, he had a lot of tightening on one side of his neck. He was very healthy, you would say that the birth was uneventful. But when you really look at the whole picture, we look at this as a baby who spent 9 months like this. And so he's going to have tightening on one side. And how this ended up playing out for her is, even though we knew this, we started exercises early, we did end up with a little bit of misshaping of the head, that plagiocephaly. And it did impact breastfeeding a little bit, right? And so we knew we had services right from the beginning because of these things. And those are some of the stuff that your higher level of care are really going to be looking out for. Lynette, I want you to jump in and give us some tips on one-sided wrestlers.
Actually, that's exactly what I was going to say. My questions earlier kind of alluded to the last one that I forgot to add was torticollis. And I think you have a great example of that. But something as simple as just switching the position, but keeping it in line with the baby and the baby's preference is something that you can quickly fix as a CLE and in your quick home visit. But Hannah is completely right. And Brandy had talked about it earlier, just knowing when to refer out, because we definitely want those babies followed up with, especially if it's like a torticollis issue or a shoulder issue where someone can help her additionally with positioning.
Thank you. And I want to ask here, where are you, Yvette? So I want to walk this case all the way through, because that's kind of where we're here, is that often the advice that we get is refer out, right? Refer out, refer out. So you referred this person out. What happened?
If I remember correctly, I think she continued to still have latching challenges on one breast, but she wanted to continue. She was motivated to continue feeding her baby. So she kept, from what I remember, because then after I just get to see them one time and then they follow up with somebody else. But she insisted on wanting to at least pump from the one breast that she couldn't breastfeed on.
Okay, well, I think, you definitely provided her the amount of support that you could, which is really great. And I'm really curious, and I wonder if the rest of the group wants to chime in here. A lot of times I think where we feel a little bit impotent or things feel really out of our control is when we make those referrals out. And one of two things happens. Either the referral's no good because it's too difficult to access, et cetera, and or the client just decides they don't want to do all of that. And so they're like, okay, well, you can't help me. Yes, I'm not going to be helped. So what does it really look like when we take a referral all the way through? Does anybody on the line have it whereby they're a lactation educator? They identify that an LC, that their client needs to be referred to an LC, and that actually works out really smoothly? Is that usually the way it goes? I'm just curious.
So I have a couple of scenarios like that, but because our hospital, and I think it's because of our director. So our director for Welcome Baby oversees both lactation and Welcome Baby. So our teams are very much connected. So we can literally call into our lactation clinic here and say, hey, I need a spot for mom on Thursday at 3. Is that open? We've had a couple of cases that have successfully worked that way. And then we're able to talk about the case so that the home visitor can follow up with the family. But that's not every single case. And unfortunately, I wish it was for everybody, but it is what it is sometimes. And I'm hoping that eventually we can create better relationships within the community so that it's more streamlined. But yeah, we've had a combo of both.
Love it. One thing I'll just say, I want to just say something about the referrals. Sometimes don't be afraid to be persistent. Because even though you give a referral doesn't mean that's the moment they're going to jump in and call the person or connect or whatever. They missed, the person called them, they didn't get back to them, and you go back, a month later and they still haven't had that intervention. Be persistent. I have a client who has a baby who has, I would say a pretty strong case of plagiocephaly. And their pediatrician is of the opinion to just wait it out and see what happens. And just do tummy time. And so it's like, that's an interesting position that they have. And so, I had to be a little persistent. I was like, that sounds okay. And that's understandable. They might say that. Sometimes though, there's things that we can do now that can prevent you needing to have help, when your baby's 5 months, 6 months, or prevent you from having to wear a helmet. And so it was percentages of me saying like, that I'm not disagreeing with your pediatrician, of course, but, let's think about a differing perspective on what this could be. You know what, I'm going to talk to my OT friend and see what she says. And she sees this every single day. And by talking to her and getting the referral and like giving her that number, I was able to then get them to actually go through and get that service where they reached out for the support. They asked their questions and their provider said, it's fine. The baby's gonna be fine. He's still little. He's only 3 months. Just do your tummy time and it'll work itself out. Which to me was really bad advice. I could just say, well, her doctor said that. So, whatever, but it was very clear to me. And if anyone saw the baby that like, yes, there is plagiocephaly, maybe it's going to work itself out. But like, do we want to take that maybe when there's so many things they could be doing now? And so I would just say that don't be afraid to be a little bit persistent. If your gut is saying, they need to see this, they need to see an IBCLC. They really should, like that torticollis looks pretty profound. Maybe they should be talking to an OT. Again, we're not there to diagnose, but that doesn't mean that you have really strong intuition and really good skills in managing cases. This is case management. And so I just want to just put that piece in there that sometimes there is resistance and it's not coming from the client. And so we have to be a little bit more persistent when that happens.
And I think it's really important to always remind them that they have the right to a second opinion. Yes. Right. You are the expert in your child. You know your child best. You know your situation best. And you have the gut feeling as a mother. So if you're not uncomfortable, you have the right to another opinion. So I think it's very important to remind them that.
Absolutely. I also think it's important for us to remind them that we are actually a partner in their care, right? So we are not the person who only, we don't oversee their care. We don't just give care. We actually are a partner in their care, meaning that if we give them a referral and that doesn't work out for them and they feel like they're not satisfied with the results, like maybe we don't have another referral. I think this might be the hardest position that I find myself in when I am dealing with clients, is when I feel like there's an issue and I don't know where to send them that's going to be easy for them, or I don't know where to send them that they're going to be able to access or get the care tomorrow when they really need it, or today, but they probably really need it. And this is, I think as a provider, this is what makes me feel the most uncomfortable, to be honest with you. And so what I try to do often is just remind myself, it's very similar to what Lynette and Brandy were talking about in their trainings, which was like Lynette said in the very early days of home visiting, it was like, go get to the beach for free. Right? Like we have to actually be the partner in their care. So if I can't find you, like we're going to go find that referral together. Let's go make that call, right? Oh, that call didn't work out. Well, let me sit here while we talk to so-and-so. Let's make this other call. Let's do, don't leave people on their own. Mm-hmm. It's okay not to have all the answers.
Thank you so much for that case, Yvette. Thank you. Who else has a case? We have time to do another one that we can hash out as a team of lactation providers. Who can think of a case? Don't be shy. Hannah, you're being so still. Is she frozen or is she just still? You were just being so still.
Me?
Yeah, I was like, is she frozen?
No.
Or is she really still?
It could very much be my internet this week. So
No, I think you were just being incredibly still.
I have that tendency too. Who I know somebody else has a challenging
Someone
case.
has a challenging case.
Polled you, and you said you did.
Pull it out. Someone has a case that didn't have a good outcome. This is a chance for you to be able to learn, but also you get to provide the chance for your colleagues to learn and jump in and see if there's anything we could do differently.
I have one, but I feel like I keep talking, so
Okay.
anyone has one. So typically, so for our Welcome Baby team, everyone's CLEs, I'm fortunate, I'm able to be the LC on the team. So the team's able to refer to me if they have a mom that rises to the level of even just like talking to the mom a little longer, because I know everyone's busy. What do you do when you have a mom that's just like, I did that? So I have a mom, very well educated. She's a physician here at this hospital, coming back to go to work. She had twins, is ready, is just preparing mentally to just come back. And so she was talking about increasing her milk supply and pumping and working that whole process out before she comes back. And she was a little defeated because she felt like her milk supply should have been higher. And I chit-chatted with her. We talked about ways to increase her supply. But her response the entire time was like, I did that. I did that. I did that. I did that. So every idea or recommendation that was had was met with, that's already been done. I don't know what else to do. I'm like, okay. I didn't know what else to give her other than recommendations for, she talked about galactagogues. And typically I like, as an LC, I like to just start very general, like the teas and not herbal remedies, but like some of the lighter things versus like just going to straight like domperidone and things like that. But I don't know, what do you do when you get hit with, I've done everything, or I tried that, didn't like
Yeah,
it?
so I'll just say one thing. So sometimes when I hear a lot of I've done everything, and this is not necessarily what's happening, but sometimes it can be an indication that maybe they really don't want to breastfeed, and that's okay too. And so I don't go in with that idea. Like, I'm always going to go with the idea that I'm able to support them and I want to help them in their breastfeeding dyad. And so one of the questions when you start getting a lot of that, I'll usually pause and say, why don't we just sit for a second and talk about all the things that you've tried already, so that we can make sure that the things that I'm giving you aren't going to be things that you've already done. And so let them talk about their care and their services. Then I also go into, why do you think some of those things didn't work? And it could be the person didn't explain it well, or they told me to do X, Y, and Z and that didn't work. So I tend to ask them for each of the things they say already did, what about that didn't work for you? And start going through those things. And then I want to get really clear about their breastfeeding goals. Is it your goal to exclusively breastfeed? Is your goal to breastfeed and provide supplementation, either through pump breast milk or through formula? Sometimes those kind of clients need you to open up. Maybe they're afraid to say, like, I have these twins. I really don't see myself exclusively breastfeeding these twins. Doesn't mean that we have to be recommending that clients use formula, but we do want to get to a real idea of what their actual goals are, that you're not just hitting yourself against the head with, I've done that, I've done that, I've done that. Some of that is frustration that's coming through. And I'd say, like, it sounds like you've tried a lot of things. That must be really frustrating. Sometimes getting them to talk about the frustration of getting all these things. You know what? And lactation consultants, we all say different things. It's probably really frustrating to get different advice from lots of different people. When you can hit them there and take away that like resistance, because they're waiting for you to pounce on them to give them another plan that's too difficult and taking all their time and still not going to work. We can stop that just by like that question, how are you? How is this for you? It must be really frustrating. You've tried already 15 things, it sounds like. That must be really frustrating. what do you want to do now? What are you hoping to get from this, session today? And I feel like when you take that time to pause and to kind of see, where is this coming from? Is it coming from frustration? Is it coming from, I really don't want to do this? Is it coming from, I don't think you can help me? Once you can kind of see where that's coming from, it's going to much better help you guide the conversation. It'll help you to guide the interventions, because then you're not just listening to a bunch of things that she already has. And so that's the first thing that I would say about that. I'm sure Hannah has things to add.
Well, I think, Lynette, obviously my mind initially, probably just personality wise, goes specific to probably where your mind went, which is like, well, what are you trying? What are the things that, have we done an oral assessment? Are we absolutely sure that, transfer is happening properly and that's not affecting supply, et cetera, et cetera. A lot of times with clients, you'll hear that they've tried everything, but that they haven't, or that the way they've tried it isn't the way that's actually going to support the physiology of lactation. And you're finding like there's this big divide between like what I'm telling you has to happen that I know will build your supply, and what you're actually engaging in and what you're actually telling me you're engaging in. And all of that puts me in a really frustrating position because you're asking me to fix it. But I think it goes back to what Brandy was saying, which is like, maybe you're not asking me to fix it. And I think maybe we need to get really clear on that. Maybe what you're asking me to do is just to use some descriptive praise with you, to acknowledge that you are a person, particularly if you're a medical doctor, who is used to having all the answers and having done everything the best that you can and having the authority all the time. And this is a situation where maybe that dynamic is being challenged. And so maybe what I need to do is point out to you that the relationship that you have, that you've created with your children in this experience is so much more than your milk supply. And what have we done thus far by doing what we've done? Where do we want to go with it? How can I support you just to get there? Because like Brandy said, it sounds like you've tried everything. It sounds like you're the absolute expert on this. I usually just give up. I mean, that sounds like terrible. Not give up, but it's kind of like a surrender to, it sounds like you have done everything. So then you're still talking to me. How can I best support you?
I think that's such a good point.
Yeah.
Yeah, I think you're right. I went in there like, I knew what she wanted to do. So I'm like, come in with my game plan. I'm like, let's do this, let's do that. And I didn't listen. Maybe she was looking for an out to say like, oh, I tried it, I'm done. And that's all she needed to hear,
And sometimes, and I hate to use this word, but I feel it. Sometimes people are looking for permission. And I hate that our people are looking for permission, because they have some people judging them on every single decision they make. They just don't want one more person to judge them. And they're looking for you to be like, oh, you know what? You've done everything. This isn't working. Okay, good. I can stop. So again, we're obviously going to be pro nursing, pro lactation, but I'm also very pro parent. And so I'm pro mental health. And so sometimes our work isn't to provide the intervention, it's to provide the space for them to decide what they want to do.
Such a good
That's
point.
a tough line. I want to say it's a tough line because sometimes, it's that like, it's really hard to determine, are they asking for permission to stop? And do I just walk them down that road where of course I, do what you please? Right. Or like, is there something where we need a further eval? I mean, from what we know about how lactation is supported physiologically, like there is so like I feel that we're learning so much more is what I want to say about how deep this goes in regards to infant oral anatomy and function, that really is even out of the scope of an IBCLC unless you specialize. And so really, really being able to like look at that and have that evaluated so that people are able to meet their goals. I can't tell you how many times I work with, because I also work in clinics that serve folks that have perhaps sometimes a little bit less access for certain reasons to extended services. Our healthcare system is so fragmented. And so if we don't offer it there at the clinic, then it's very difficult for them to access. And because of that, what I see a lot of times is like, I want to make sure that we're looking at every single angle. If there's a possibility that we can have you succeed at this through additional services, I want to make sure we're going there as well. But I guess, I need your buy-in for that.
Yeah, good point. I probably also felt additional pressure because she was a provider at our site. So I'm like, oh, got to perform because I wanted to like the program so she can recommend it to families. It's just all this stuff going on in my head in the background.
Of course.
I don't know, there's just a whole bunch of stuff. But I think those are great points to not go in gung-ho and just to kind of meet her where she's at and just listen, right? Is what I'm picking up. Just, see where she's at that moment.
Yeah, all of us healthcare people tend to be the worst patients, by the way. We're usually the worst patients. So I think a lot of people experience, like, you're used to being the one that's doling out the advice and whatever. It's hard to be in that space of receiving for a lot of people. So what else would you guys add for this case? What do you have to offer? What questions might Lynette ask of this, client who is basically saying she's done everything that Lynette has said? What else would you add? How would you shift the conversation in ways that we haven't talked about thus far? Because everyone will experience that client at some point in there. If you haven't already, you will experience it. I did that. I tried that. I've done that. I bought that. I did that last Thursday. You're going to get that. And so it's how do you, because basically what happens there is you're at a standstill. And so
that's what I felt. I was like, okay, what else? I felt really dumb, honestly. I was like, all right, this is not really going anywhere. So I try to like wrap it up and I'm like, let me give you some resources. She's like, oh, I've already gotten that resource. I'm like, all right. I was like, well, I was like,
nice seeing you.
Yeah. I was like,
you know what I love about you sharing this, Lynette? Okay, this is what I love about you sharing this particular case, Lynette, is that I want like everyone to hear really clearly, like Lynette was, thank you for like actually telling us, because we all go through it and then we don't talk about it, is when you were preparing to go into that room or that consult, right? You already had the feeling of like, oh my God, maybe I'm not going to be able to provide everything this person needs because this person's an MD. Like they're a doctor, I'm not. And maybe like, I got to be everything to this person. And not only were you not everything, you were like less than you even thought you could be with any client. You just like fulfilled the whole prophecy of everything that you had created in your mind, right? It was like the worst possible case scenario was like you gave her absolutely nothing that you felt she could value.
Yes, absolutely. I was like, I didn't know what else to say.
Yeah, right. And so like, I'm glad you said it, because at the end of the day, like, I think that, it comes back to a couple things, which is number one, our intention sets the outcome for absolutely everything to come. It always will. And I know that's a little woo-woo, but really when you think about it, when we're talking about educating, we're talking about impacting really, really deep-seated, long invested in ideas about health behaviors, personality traits, learning styles, et cetera, we're not going to be able to move or shift those things if we are really feeling from the beginning like we're probably not going to be able to move or shift those things, right? And so really just setting an intention when we have that, like, I'm not sure what I have to offer this client. I know for sure, just like Lynette said, I can offer her a listening ear. I know for sure I can go in there and give her these resources, whether she takes them or not. That is not my piece of things. So I just think it's interesting that you brought it up, because I think we've all been in that position, and it maybe not be with someone who is like a medical provider, but it may be like circling back to what we talked about in the beginning of this, somebody of a different culture of ours, somebody that we don't feel we can relate to, we're intimidated by for some reason, or we're not sure where the connection is. Or they have a really challenging case and we're just not sure like how to start with it. So I really appreciate that. Thank you.
Thanks so much for sharing that vulnerability, because we've all been there. And the practice is that sometimes we're not going to be able to help a client. And that really is hard, because we get in this to help. We get in this to solve problems, but not everybody wants us to solve their problems. And that's a hard pill to swallow when you're a problem solver. And so, again, it's not the idea of giving up, but creating space for the session that the client wants, and not what our expectation is for the session. Is something that we all should be working on. Your goal was to go in there to help with her breastfeeding. But we don't know what her goal was for that session. And so part of that work is figuring out, does your goal match the client's goal? And that takes us asking more questions, being more curious, listening more, and really helping them to clarify what it is they're hoping to get out of our session. By doing that, we can reduce lots of barriers. We can deal with frustration. We can deal with overwhelm. We can deal with the idea that they think nobody gets them or understands what they're going through just by doing those few things. And so with that, that brings us to the end of our session. Do we have any questions or anything that we can answer for anyone that we missed for you? Yes. I see Hannah saying, let's be clear, Lynette is the best of the best. So if she's sharing this, then we know we all face it. Yes, that is for sure. I know I do. I'm sure all of us have had those moments where just like, I just don't know what to tell you. Like, I've tried everything in my tool belt. I have taken it out and given it to you, and it did not land well. So, you know, we've all felt that. Yeah, Lynette said she felt defeated in the moment. Yeah, it's hard. And this is why we need this. We have to have spaces like this where you can talk about those feelings. We can talk about things we could have done differently, because sometimes there are things that we could have done differently, and sometimes there aren't. Sometimes it's, you know, a bad day for that client, or it's a personality mismatch, or whatever the case may be. They don't want to breastfeed, or they don't feel like talking about that today, or their mom died before you came. You know, so it's just all those things that we can't always say that we're going to be able to have an intervention, but we have these spaces to come and talk about cases, to talk about how we might think about things differently, how we might phrase something that opens more dialogue and connection, is the work that we really want to be doing together. Yes, Hannah says we need to reimagine what winning looks like. And so I feel like winning looks like spending 4 sessions with home visitors throughout LA County, thinking about how we can provide better services for parents to create healthier babies and healthier communities. To me, that is winning. And so I am very grateful for you all. If you came to only this session or to all of them, we're thankful for you taking the time to think about creating space, to think about creating connection, community, better outcomes for breastfeeding, and supporting the clients that we have in the community. So we thank you for that. With that, that will be the end of our session.
Take care, everyone. It was nice to see you.
You are so welcome.
Guys. Yeah, I've done a couple of other trainings, and I felt like these are really, really good. So thank you for, you know, being really thoughtful and putting these together. They're very helpful.
Thank you. Thank you. Do fill out that evaluation so we have it in writing. We want it in writing.
Yeah, we just not in writing. It didn't happen, Lynette. You're so welcome, Shayla. You're so welcome, Yvette. Have a great day. Hopefully take some time, some you time as you're working to serve our community. Thanks so much, everyone. Have a great day. Bye.